All right. Good afternoon, everyone. My name is Priscilla Calvache. I am the Assistant Director for Lupus Programs and Community Engagement at Hospital for Special Surgery. It's truly a pleasure to welcome you all to our live stream, Living Healthy with Lupus program. And this is a special program sponsored by the Department of Social Work Programs at HSS for the past 16 years. Just some information on the Department of Social Work Programs at HSS. We offer the most lupus support and education programs in the country. All of our programs are free, are available in English, Spanish, and Chinese. And for more information about our support programs and the Department of Medicine, I encourage you to please visit our websites, which are going to be included in the chat box shortly. So today we're excited to be joined by Dr. Henry Lee, who will be leading an interactive presentation on lupus and the skin. And before we get started, just a few brief housekeeping rules. You'll be muted during the presentation, but we're highly encouraging your participation by sharing your comments and your questions in the chat box. We will have time to answer your questions live at the end of the presentation, and Dr. Lee will also be addressing questions that were submitted during registration. Lastly, I'd like to introduce our program evaluation. Your feedback is so crucial and important to help us inform future programs like today's. So we'll be embedding that survey link after the talk, and we hope that you're able to complete this brief survey before the conclusion of today's program. So without further ado, it is my pleasure to introduce our speaker this afternoon, Dr. Henry Lee, the Associate Attending Physician at New York Presbyterian Hospital and Associate Professor of Dermatology at Weill Cornell Medical College. Dr. Lee's practice focuses on medical, surgical, and cosmetic dermatology. He has a broad interest in medical dermatology, but pursues a particular interest in autoimmune cutaneous disorders in collagen vascular disorders. Dr. Lee received his Bachelor of Science in Biology with a concentration in anthropology from the Massachusetts Institute of Technology. He pursued his medical studies at Tufts University School of Medicine, where he received an MD PhD degree. Dr. Lee completed his internship in internal medicine at the UCLA VA Greater Los Angeles program, and he completed his residency in dermatology at New York Presbyterian. Oh, so sorry. Well, without further ado, it is my pleasure to welcome Dr. Lee today. Thank you so much for joining us, Dr. Lee.
Oh, thank you very much for inviting me and having me. I'm really excited to speak to all of you about a subject that's very near and dear to my heart, that is cutaneous lupus. I also wanted to thank all of you for submitting some questions beforehand. I had the opportunity to go through those, and when possible, I tried to work some of those questions into the talk. So let's get started. As all of you already know, systemic lupus is a chronic autoimmune condition, incredibly protean in its presentation, and can involve any number of a system. The commonly involved systems are the joints, the skin, the kidneys, and the hematologic system. Given the sort of variation in presentations, it can be an incredibly difficult diagnosis to make, and can oftentimes require an experienced specialist to make that clinical diagnosis. Oftentimes, that would be your rheumatologist in this case. They will utilize a constellation of signs and symptoms that the patient presents with. They'll use supportive serologic studies, and they'll rule out other conditions that could be, and then arrive at the diagnosis of systemic lupus. This is an incredibly busy slide. I think the take-home message here are that it's been traditionally very difficult to sort of study a homogeneous population of lupus patients. And so several attempts have been made to do so. And on the very far left, it's the traditional sort of research criteria that were used to try and identify a homogeneous population of lupus patients. And that's the American College of Rheumatology criteria set forth in 1997. There were 11 criteria, and 4 of which were dermatologic. And I highlight this to just illustrate the major role and importance that cutaneous findings play in the diagnosis and management of lupus patients. So the 4 dermatologic manifestations were that of a malar rash, otherwise known as a butterfly rash, photosensitivity, discoid lupus, and oral ulcerations. There were some pitfalls and shortcomings of this criteria set. And so as time went on, new sets have been made, perhaps to create an even more homogeneous patient population that more accurately represented lupus. And that is in 2012 and 2019, 2 new sets were set forth. A little bit more complex than the ACR criteria, but essentially from a dermatologic standpoint, still including the malar rash or photosensitivity, discoid lupus, as well as other manifestations of cutaneous lupus, still including oral ulcerations, but also including alopecia, medical term for hair loss. So how many of the systemic lupus patients actually develop cutaneous manifestations? Well, it turns out by certain studies, as much as 80% of systemic lupus patients will develop some form of cutaneous involvement during the course of their condition. And in fact, maybe up to almost a third of these patients may develop more than one cutaneous manifestation. A very sort of confusing aspect is that cutaneous lupus does not equal systemic lupus. They are not the same. Many patients develop cutaneous lupus without developing systemic lupus. In fact, the majority do not develop systemic lupus, and we'll delve into this a little bit more later in the talk. As many of you already know, cutaneous lupus has many different manifestations. They are largely categorized into 3 broad categories, and those are sort of illustrated here. Acute cutaneous lupus. The hallmark representation of this form of cutaneous lupus is that of the butterfly rash. Subacute cutaneous lupus, otherwise known as SCLE, and chronic cutaneous lupus, which has many different forms. Probably the most commonly found and most discussed is that of discoid lupus, but we'll also delve very briefly into tumidus profundus and chilblains as well. So the first category is that of acute cutaneous lupus. And again, the hallmark feature is that of the malar rash, otherwise known as the butterfly rash of lupus. There are other forms also of ACLE or acute cutaneous lupus, including this generalized acute cutaneous lupus. These non-specific sort of faint pink papules can be very difficult to diagnose clinically, and oftentimes we have to rely on a biopsy, which we'll discuss later in this talk as well. Somebody asked if lupus patients were more prone to develop rosacea, and so I sort of prepared this slide to sort of address that question. And no, you are not more prone to develop rosacea if you have lupus. But what is interesting is it can be very difficult to distinguish clinically sometimes between the malar rash of lupus and rosacea. So this again is the butterfly rash here on the left side of your screen. And this, although it doesn't portray very well, this is a rosacea patient with erythema on their cheeks, on their chin, and across their nose, somewhat similar to that of a malar rash. Next, moving into subacute cutaneous lupus, or SCLE, this form of cutaneous lupus is incredibly photodistributed, oftentimes involving, as you would imagine, the photoexposed areas of the skin, extensor arms, the V of the chest, superior back and shoulders. And this photo on the right sort of really does depict how incredibly photodistributed it can be. In fact, you can see the outlines of this person's swimsuit. She had a 2-strap sort of swimsuit with the straps providing photo protection and hence no development of SCLE in those areas. The primary lesion is oftentimes psoriasiform, as depicted in this photograph, red and scaly, and then can be, in fact, it can be annular as well. Annular meaning ring-like, and these rings can oftentimes coalesce into a polycyclic pattern. Again, this is the photo-distributed pattern, the V of the chest that is so commonly found with SCLE. Roughly half of the patients with SCLE will go on and have or already present with systemic lupus, and maybe 10%, a tenth of systemic lupus patients will at some point exhibit SCLE. In my experience, it hasn't been quite that high. Next, moving on to chronic cutaneous lupus, and perhaps the one that most of you have heard of is the discoid lupus, and this is far and away the most commonly found and discussed form of chronic cutaneous lupus, but we will touch on some other manifestations as well in a little bit. So discoid lupus, as many of you know, are these erythematous plaques, often covered by an adherent scale. This scale can extend into the hair follicles, thereby sort of creating what looks like this follicular plugging. There is oftentimes inflammation at the periphery, and that is how the plaque actually expands, by expanding at the periphery. It sort of burns itself out sometimes centrally, and so you can get central scarring with dyspigmentation, which refers to that there can be other colors, sometimes lighter in color, sometimes darker in color. These are some manifestations of discoid lupus. It really does most commonly occurs above the neck. This is a picture of scalp involvement, can oftentimes involve the face. This is more an example of burnt out discoid lupus with essential scarring and dyspigmentation. And this photo also depicts that it's very common that the ears and the caudal bowl are oftentimes involved. DLE is by far and away the most common form of cutaneous lupus, making up nearly 3/4 or even more than 3/4 of all cases of cutaneous lupus. That being said, it's only a minority of discoid lupus patients that go on to develop systemic lupus. Depending on the study that you read, it can be anywhere from 5 to 10% of these patients go on to develop systemic lupus. The interval between onset of discoid lupus and systemic lupus, the range that's been described in the literature ranges anywhere from 4 months up to decades. That being said, the vast majority do develop systemic lupus within a few years of their discoid lupus diagnosis. It'd be wonderful if we could predict which one of these patients are at higher risk or would develop systemic lupus. Currently, we do have some clinical sort of features that may suggest a higher chance of developing systemic lupus. I mentioned earlier that the majority of discoid lupus cases occur above the neck. That's considered to be localized discoid lupus. If the lesions occur above and below the neck, that's sort of considered to be generalized lupus, discoid lupus, and that may double your risk of going on to develop systemic lupus. Some small studies have also looked at clinical criteria to see which one of these patients may be at a higher risk of developing systemic lupus. Some of the criteria that have been examined include arthritis and also include periungual telangiectasias, which are these little blood vessels that live in your proximal nail fold. And then the other way to look at it is what % of systemic lupus patients actually exhibit discoid lupus, and that's about 1/4 of systemic lupus may develop discoid lupus at some point in their condition progression. It's also really exciting to think about if we can really find out who it is that would go on to develop systemic lupus. Perhaps we can intervene and prevent the development of systemic lupus, prevent progression, or even prevent SLE flares. Lupus tumidus is a much rarer form of chronic cutaneous lupus, and it can look very innocuous. This photo is very hard to appreciate, but it's sort of almost this dermal plaque, which means it's not quite at the surface, but it's a little bit under the surface of the skin. And there's clearly erythema there as well. The other sort of interesting feature is that there is no surface change, unlike discoid lupus. There is no scaling, just this sort of edematous plaque with erythema. Like like SCLE, and oftentimes like DLE, this does involve sun-exposed areas. Lupus profundus can be very difficult to portray in photographs. These are deeper plaques and nodules that may have some overlying erythema, and this actually lives in the skin or underneath the skin. These lesions may have overlying discoid lupus at the surface. They can be tender, and oftentimes when they heal, they leave behind these depressed little plaques and lipoatrophy. Roughly a third of these patients will have concurrent discoid lupus, and roughly a tenth of these patients will have concurrent systemic lupus. Chilblains is erythematous to violaceous edematous macules and papules that occur in the acral areas. Usually the feet are the most common, and toes are the most commonly found areas. This usually starts with cold weather and is brought about by exposure to cold weather, and improves with better clothing, better socks, better shoes and boots, boot warmers, and improves as the winter subsides and we get into warmer weather. So going back to that really busy slide, cutaneous findings play a very important role in the research criteria and diagnosis for systemic lupus. We talked about the malar rash or butterfly rash. We talked a little bit about discoid lupus, and I didn't want to spend too much time discussing the sort of nuts and bolts of the clinical findings of cutaneous lupus. I just wanted to sort of take you on a whirlwind tour so we could spend some time perhaps talking about lifestyle modifications and maybe a brief introduction into the medications that are used in cutaneous lupus. But I did want to spend just some brief time discussing some other of the cutaneous criteria, and that would be mucosal ulcerations, photosensitivity, hair loss, and then we'll end with some non-specific cutaneous lupus manifestations that can occur in a host of other conditions as well. And then this would wrap up sort of the clinical presentation portion of cutaneous lupus, and then we'll move more into therapies and lifestyle modifications that can help tame cutaneous lupus. So let's start with mucosal ulceration. This can occur in anywhere from 10 to half of systemic lupus patients, usually painless. Doesn't seem to be a high correlation with systemic activity. And again, this is not specific to lupus. The other time we can see mucosal ulceration also is as a side effect from medications that we use to treat lupus. We oftentimes do come across that as well. Photosensitivity. This is simply refers to the fact that you can develop a rash after ultraviolet light exposure. Roughly 60% of systemic lupus patients will exhibit this. And again, this too is not specific to lupus. Hair loss. I wanted to start by saying that discoid lupus is probably the most common form of hair loss that we see that's lupus specific in our patients. And this is again the sort of scarred down lesions of a burnt out discoid lupus. Almost exclusively, discoid lupus will lead to a scarring alopecia. And by scarring, we mean that there is destruction of the hair follicles. So by definition, these areas that are scarred down and have loss of hair follicles, there is no chance of hair regrowth in those areas because, again, the hair follicles have been lost. Another form of alopecia or hair loss in our lupus patients is the non-scarring variety. And again, because it's non-scarring, the hair follicles have not been scarred and damaged, and the hair can and oftentimes does regrow. We can see this with lupus flares, acute lupus. We can also see this with an entity known as telogen effluvium. And what this refers to is that the vast majority of our hair is in a sort of growing stage. But if and when we are to become incredibly sick or stressed, whether it be a big surgery, a long hospitalization, our hair shifts into sort of a shedding stage, and big, large clumps of hairs can fall out in a short period of time. and this is known as telogen effluvium. Thankfully, although it's hard to believe while you're going through telogen effluvium, after your body recovers from this acute stress, the hair will regenerate and grow back. Alopecia areata is an autoimmune condition in which your immune system actively attacks the hair bulbs. And this can lead to hair loss. And that's what this photograph depicts. These sort of non-scarring, non-inflamed, very well demarcated circular patches of hair loss. And alopecia areata, being an autoimmune condition, can occur at a higher rate in many autoimmune conditions, including lupus. The last category of non-scarring alopecia that might be specific to lupus is medication-induced hair loss. An example of this, and I just saw this fairly recently, although retinoids are not oftentimes used in the treatment of lupus, we saw a patient that was on retinoids for other reasons, and they did have quite a bit of hair loss or alopecia. The last point that I wanted to share with you, though, is common forms of hair loss are common, and probably the most common. And having lupus does not mean that you are not susceptible to those common forms of hair loss. So androgenic alopecia, otherwise known as female or male pattern hair loss, is probably the most common form of hair loss that we see in our lupus patients. Now, to briefly share with you some non-specific cutaneous manifestations of lupus, I wanted to show you livido reticularis, which is sort of this lace-like redness and violaceous patches, usually found on the distal legs. Vasculitis, which, as many of you know, is inflammation of the blood vessels. Again, none of these are specific to lupus. Vasculitis, the hallmark sort of finding would be that of palpable purpura, which means sort of like these non-blanchable, violaceous little papules or bumps that you can feel. The most common area, again, in my experience, are the shins and legs. And then Raynaud's, which is this sort of discoloration of distal fingers and toes upon exposure to cold weather. This is a final stage. It's sort of like a whiteness, a blanching of the fingers or toes. So oftentimes we rely as dermatologists on a skin biopsy to help us make a diagnosis, whether it be the malar rash. Sometimes we will biopsy. As I said, it can be very difficult to discern it from rosacea. We recently had a case where it was incredibly difficult to sort of differentiate between, was this really rosacea or was this acute lupus? The subacute cutaneous lupus form, oftentimes we have to and will do a biopsy as well. And this is no different than the chronic cutaneous forms as well. The most common form of a biopsy that's done for the skin in lupus is that of a punch biopsy. And this little cartoon is meant, and I think does a very good job of depicting what a punch biopsy entails. Sometimes we even do more than one biopsy because we may send one for special studies. But essentially, we anesthetize an area of skin with a local injection, local anesthesia, brief pinch, and a brief moment of burning as the anesthesia seeps in. And after that, it's instantaneous. You can feel pressure, but nothing sharp and no pain. We take a little coring device, a punch biopsy device, and we core out a small cylinder of skin, and we can control the diameter of this punch biopsy depending on our needs and sometimes how deep we want to go. The larger the diameter of the punch biopsy, the deeper it allows us to go into the skin. Oftentimes these are then, after the core is removed, we simply put a suture or two in, and then you're on your way. The whole process might take, including setup, maybe 5 to 10 minutes. So now that we've talked about some of the different manifestations of cutaneous lupus, I wanted to spend a little bit of time talking about the therapeutic ladder, or some of the therapies that we use for cutaneous lupus. We did indeed receive many questions about some of the therapies. And so I wanted to sort of spend the time discussing the therapies for mild or localized disease, because these are fairly straightforward for cutaneous lupus. And we'll start talking about sunscreens. We'll move on to steroids, topical steroids, intralesional steroids. We'll talk about topical immunomodulators, and we'll spend a little bit of time talking about antimalarials, and specifically hydroxychloroquine, or as the brand name is known, Plaquenil. So as we discussed earlier in this talk, photosensitivity plays a large role in the diagnostic criteria or the research criteria for our lupus patients. And this again is the formation of a rash after UV exposure. And what's really interesting is that we have good data showing how sensitive many of our lupus patients are to UV light. We know that UV exposure can act as a potential trigger for skin eruptions. And rarely, this can even lead to UV triggering internal flares of lupus. So given the dangers of UV exposure, it just makes common sense to be safe and to practice good sun protection. So here are some practical sun protection tips that I wanted to share with you. You know, many of you are enjoying your lives and have activities that you enjoy outdoors. We really want you to avoid exposure to UV during the hours of maximal ultraviolet light. So try to do your activities much earlier in the day or later in the afternoon. Protective clothing is very important, and I've depicted a photograph here of a very wide-brimmed hat that can help protect not only our scalp, but our ears and our face, and in this case, even our neck, or at least the back of our neck. UPF clothing is also very important. The place that I see this used the most is perhaps in golfers who can wear UPF sleeves or even UPF shirts. We often see many of our patients use this who are tennis players or at the beach or in swimming pools. Protective habits, which include sitting at the beach perhaps, but under a parasol, not directly in sun, getting tinting of your windows. Until fairly recently, the DMV of New York State did not recognize the dangers of UV exposure for our lupus patients. That has thankfully now changed. Before we had to write letters to the state to get individual approvals, but they now really do recognize that lupus, the patients need to have their tinting of their windows. And the two places that I see this most commonly are for cars, for people who have long commutes to work, our patients who work as drivers. We really do want to help them by tinting their windows. And finally, office workers as well. In fact, recently we had a school teacher who has lupus, and her classroom is inundated with sunlight throughout the day. And we were having difficulties taming her cutaneous lupus. And so finally we got her school to tint all the windows, and she's actually doing a little better now. And finally, perhaps one of the cornerstones is that of sunscreens. And a question that we get often, and the questions that we received before this talk were no different, was how do I choose a sunscreen? I know this is very difficult to answer, but before I do that, perhaps I'll spend a little bit of time giving you background on what sunlight is. And so this will better explain what we're looking for in sunscreens. Well, so sunlight is a wide range of electromagnetic radiation or energy, and they all differ in wavelength of the energy that is being emitted, with infrared being at the longer length of wavelength, the ultraviolet or UV spectrum being at the shorter spectrum, shorter wavelengths, and the visible light being sort of in the middle. And we need to ensure that UVA and UVB are both being adequately addressed for our lupus patients. UVC, we don't really need to worry about because this really does get filtered out by Earth's atmosphere. So it's UVA and UVB that we're concentrating on. Some quick sort of facts about UVA and UVB is UVA does have a longer wavelength, and as such is better able to penetrate clouds and windows, but is not pound for pound, maybe not as damaging as UVB is. UVB is a shorter wavelength. It's more readily filtered out by clouds, but pound for pound, it does pack more of a punch than UVA. So many of you asked about SPF, which is short for sun protection factor. Again, this is a very busy slide. I think there's 2 take-home points from this, and that's that SPF is a measure of only UVB protection. It does not mention or have anything to do with UVA protection. The other take-home point is that it's a numerical scale, and I'm sure many of you are familiar with it, but there's sort of diminishing returns as we get higher in the SPF numbers. So SPF 15 filters out roughly above 93% of UVB, and SPF 30 filters out 97%. So there's a minimal gain there, but really going above 30, you may not gain all that much. We already have quite a high level of UVB protection. And so that's why with many of our patients, we'll recommend an SPF 30 as a reasonable number. I think the more important thing is to make sure that you put on an adequate amount, because these studies were really based on more or thicker amount of sunscreen that's applied than probably the average consumer. And then the other important caveat is that you are very proactive in your sunscreen application and applying it perhaps every 2 hours or whenever you dip in the water and come back out again. So again, SPF only measures UVB, but we also want to ensure that there is adequate UVA protection. We don't have a very good UVA protection scale like SPF is for UVB, but what we're going to look for is that these labels should clearly state broad spectrum. And thankfully, the vast majority of our products, sunscreens out there, are both a broad spectrum and adequate SPF. So again, UVA is a little bit trickier, given its longer wavelength. It can penetrate and is not as easily filtered, still makes it through clouds. And so on cloudy days, we do not want our patients to be thinking that they're fully protected from UV and venturing outside without their protective clothing, without their sunscreens on. And again, sitting next to a window does not protect you. As we discussed earlier, the importance of tinting, and that's largely because UVA makes it easily through glass. This is a photograph that I took from a very famous dermatology textbook, and this is just to show you that windows are not photoprotective. This is the same patient. This is 2 sides of her face, and clearly one side has much more sun damage. And this is the side of the face that was facing the window at her workplace for years on end. And this is the side of the face that did not face the window. Again, this really does demonstrate, I think, quite vividly that windows, typical windows, are not adequate at filtering out UVA. The last thing I wanted to impress upon you about sunscreens is that I do not want you to think that sunscreen use gives you carte blanche to run around outside for prolonged periods in the sun. You should not utilize sunscreens as a method of prolonging your sun exposure. And so now that I'm sort of done giving my little spiel about sunscreens, I wanted to spend a little bit of time talking about other lifestyle modifications that can benefit our patients. And that involves both smoking and then some tips for patients who may have Raynaud's. So the data is very clear that there's an increased prevalence of smoking in discoid lupus patients. And there's data that shows a trend that smoking is a risk factor for systemic lupus and perhaps discoid lupus. And then there's furthermore, there's data to show that at the outset of discoid lupus, there may be an increased extent of disease, in fact, more generalized cases in smokers. Not only that, not only is smoking associated with more extensive presentation, smoking may also make one of our cornerstone therapies, anti-malarials, less effective. So smoking really does have the potential of being a double whammy, making your actual condition clinically worse, and then also perhaps making anti-malarials less effective. Raynaud's, the whole name of the game is to keep warm. I remember when I first started taking care of Raynaud's patients, I was so focused on just the hands and the feet, advising our patients to buy incredibly warm boots, thick wool socks, using toe warmers and hand warmers. I love these USB rechargeable hand warmers. Many of our patients will walk around with one of these in each pocket of their jacket or coat. The use of mittens or gloves is paramount. But what I didn't sort of focus on until maybe after having been in practice for a little bit was the importance of keeping the ambient core temperature warm, not only the hands and the feet, but also the whole body in general. And so this really illustrates the importance of warm hats during winter months. And so you'll see many of our patients now really bundled up, adequately protected from the elements, not only with gloves and boots and hand warmers and toe warmers, but also wonderful hats. Even opening a freezer can set off somebody's Raynaud's. And then the joke that we make, and we have many patients who might run away to sunny climates, Florida or Hawaii or California during our cold winter months. They undoubtedly do very well while they're in these warmer climates and do worse upon return. Wouldn't it be nice if our insurances could all send us off to enjoy some warmer climate during our harsh winters? So now we'll talk a little bit and spend a little bit of time discussing some of the therapies that we employ in the treatment and therapy of cutaneous lupus. I'm sure many of you are familiar with topical steroids. This is often one of the first things that we reach for, and we use this in conjunction or in combination with many of the other therapies for cutaneous lupus. Topical steroids come in a number of different sort of vehicles. They can come as creams, ointments, solutions, gels, mouth paste, even tape. And what we're really leveraging here is we're trying to find the best vehicle for that anatomic site. And so that's why you may, and it can be frustrating, your dermatologist or rheumatologist may give you many different kinds of topical steroids. And the reason for that is sometimes we need stronger steroids for certain anatomic areas. Sometimes we want to avoid stronger steroids for certain anatomic areas. For example, the main side effect that gets discussed with topical steroids is that of atrophy or thinning of the skin. Given that risk, we want to use lower potency topical steroids for sensitive areas such as the face, the groin, perhaps the armpits. And whereas hardier skin, your hands, your elbows, or your body, in fact, you might want to use stronger steroids or a higher potency steroid. The other factor is the vehicle. If I give you an ointment for use of a steroid in your scalp, I'm not doing you a very good job because those ointments are very difficult. They're so greasy to work through your hair and actually get down to your scalp. And so we'll leverage the solution formulation for those areas. And so I just wanted to give you an insight into why it is that you might leave your physician's office with many different topical steroids, both differing in potency as well as different vehicles to maximize efficiency for different anatomic sites. Some of the other risks of topical steroids outside of atrophy is hypopigmentation, meaning it can turn your skin a little bit lighter in color. And also, if we were to apply them sometimes around the eyes and in the eyes, prolonged use can develop cataracts or even glaucoma. Sometimes topical steroids are not so effective. They have a difficult time penetrating through the skin to get down to where the action is. Perhaps the inflammation is a little bit deeper in the skin. And for those cases, the topical steroids just might not cut it because they don't penetrate deep enough. So we will take advantage of the ability to do injections. And then these very small needles can then be introduced into the skin, and we can drop the steroid right at a deeper level, right where it needs to be. Oftentimes, you'll see us use these so-called topical immunomodulators. The way I like to think about them is that they, like the topical steroids, are anti-inflammatory. They can down-regulate the local immune response just like a steroid would, but without that risk of atrophy. These immunomodulators, and the two most common ones are pimecrolimus and tacrolimus, or the branded names are Elidel and Protopic. Although they don't carry that same risk of atrophy, they don't carry that risk of glaucoma or cataracts, they do come with a black box warning from the FDA. Just wanted to briefly discuss this because you may have seen this in your packaging insert if you're using this product. This black box warning links it to a possible link to malignancies. This really is poor data. It's found in animal studies and also in human patients, but not so much patients who are utilizing a topical form of these immunomodulators. These are patients who were orally ingesting the immunomodulator. The next category of medications that I wanted to briefly discuss is that of antimalarials. This really is a cornerstone of many of our therapy regimens. Helps tremendously prevent and lower the severity of cutaneous lupus, as well as joint signs and symptoms. I always wondered how it is that antimalarial medications came about to be used for the therapy of cutaneous lupus. And it turns out, or collagen vascular disease in general. It's just an interesting side story. It turns out that this arose out of World War II, out of the Pacific sort of Rim battles that raged on. The biggest enemy for both sides in this area was thought to be actually malaria. And so a great deal of energy and money was spent by the United States government to develop synthetic antimalarial medications. And this is a later generation, the hydroxychloroquine, but the same concept applies. And they had our forces all ingest the antimalarial medications while they were stationed and fighting in the Pacific Rim. Population studies of these soldiers then showed that they had an improvement in their skin and their joint symptoms. And so somebody came back and did the data analysis, and then this became sort of the first real standard of care that had any meaningful impact for our patients. So Plaquenil, or hydroxychloroquine, is used for persistent rashes. There is some evidence that early initiation may delay systemic onset. Very well tolerated for the majority of our patients, but some of the common side effects that I have encountered are gastrointestinal symptoms, nausea, emesis, which is vomiting, diarrhea. The one that gets all the press is that of eye changes and retinopathy, which is irreversible. And that's why if you're taking hydroxychloroquine, both your dermatologist and your rheumatologist will continually ask you when your last eye exam was to ensure that you're being properly screened for eye changes or retinal damage. The frequency of eye exam really depends on the dose and the milligrams per kilogram weight that you're on. It also depends on how long you've been on the antimalarial. One of the most commonly used sort of screening regimens is that of an annual eye exam. Another side effect that we encounter is that of this blue-gray hyperpigmentation, oftentimes found on the shin. And this is a photograph. Please disregard these darker blue marks. That's just my marker depicting where I wanted to potentially do a biopsy. But this background, bluish gray hue in the skin, this was later on biopsy proven to be hyperpigmentation from plaquenil or hydroxychloroquine exposure. Yeah. Okay. It's sort of another sort of aside on the antimalarials is there is hydroxychloroquine. Another one that's not used as commonly is chloroquine. And then there's another medication that I really did like to use and layered on top of hydroxychloroquine, and that's of quinacrine. And we oftentimes use that for treatment-resistant discoid lupus. And it's worked like magic in the majority of my patients. Unfortunately, quinacrine is not on the market right now, and I'm sort of always eagerly awaiting its return. And so we have now had to turn to and rely on other therapies for cases that did not respond to the therapies that we discussed previously. And so I'm not going to really discuss this, but at great depth. But methotrexate is a very commonly used medication, an immunosuppressant with a long history, long track record that we've used for treatment-resistant discoid lupus. In the absence of quinacrine, this is the first agent that I reach for to try to tame our cases of cutaneous lupus. I'm very excited by a very newly approved medication, Safnello or anifrolumab. This was probably FDA approved in 2021. And although not FDA approved specifically for the use of cutaneous lupus, the initial data and trials that were used to obtain its approval for systemic lupus really did show in some subset analysis that cutaneous lupus patients did very well as well with Safnello. And then finally, thalidomide, which is sort of the one of the last options that we use for discoid lupus, but has an incredibly high success rate. Very difficult medication to prescribe, chock full of potential side effects, and is actually under a REMS program, which means that the FDA really wants us to register and log all the patients who are going to be treated with thalidomide. By the way, none of these medications are officially FDA approved for the treatment of cutaneous lupus. So, to recap, what can one do to sort of improve their skin quality and reduce the chances of having cutaneous lupus or cutaneous lupus flare? Just to review some of the things that we discussed already, it's about sun protection and sun avoidance, the use of protective clothing, the use of parasols, the timing of day that you do your activities, the tinting of windows, and also the use of sunscreens. Again, I think many of our patients are very sort of educated and savvy and understand the importance of sunscreen application. I think where many might fall short is that they're not applying a thick enough amount and that they're not reapplying as often as they should be. And again, we'd like it to be every hour and a half to 2 hours or after any water exposure. I wanted to highlight the importance of good compliance with the medications and the regimens that were sort of derived at by your physician to stay compliant with your clinical visits. A lot of these medications can be tricky to use and may require frequent lab checks and monitoring. We want to make sure that these medications are not harming you. The importance of smoking cessation for cutaneous lupus, and then if you do suffer from Raynaud's, again, all the warm clothing strategies that we discussed earlier. So, that concludes my talk. I wanted to leave some time entertain any questions that you might have. And I wanted to again thank you again for your interest in this topic, for sending in the questions before we even started the talk.
Thank you so much, Dr. Lee. That was very comprehensive. Just a reminder to please submit any questions in the chat box. We're going to start with several questions, Dr. Lee, that have come in regarding sunscreen and photosensitivity. Many patients are asking if there's any specific brand of sunscreen for autoimmune and allergic skin, or is it just protection that includes UVA and UVB?
Yeah, no, I think that's a great question. So, I think it's very difficult, and I don't want to have sort of brand allegiance. And the only way to make any real concrete recommendations would be if we had trial data, right? So we had sunscreen A, B, C, D, and E, and we did a randomized control trial to look at how patients perform, or even an intra-individual trial to see how these lupus patients reacted. There's only one very weak study that I'm aware of, and there's many confounding factors. The largest of which is the study was funded by the manufacturer of a particular sunscreen. And that study found that that particular sunscreen did the best of the sunscreen studied. The name of that sunscreen was actually Antelios. It's put out by La Roche-Posay. It has a proprietary chemical in it known as Mexerol. It's actually the Mexerol compound that's found overseas. It really hasn't been, it has not been FDA approved in the United States. So and I don't like to go through all that story with each of my patients. So what we end up doing is recommending, SPF 30, broad spectrum, and then the thick application and the reapplication is what we really reinforce with our patients. I hope that answers that question. So.
Yeah, and just a quick follow-up to that. So would you say that there's any benefit between mineral or chemical sunscreens, or?
Yeah, that's another great question. So, there's a lot of press coming out now about, the dangers of potentially chemical sunscreens. And then if you dig deep enough, there's a lot of articles coming out about the dangers of nanotechnology. And nanotechnology is, I think to put it quite simply, is the technology that allows us to take these physical sunscreens, zinc or titanium, and grind them up into the really small pieces. So if you follow all this, it can be very confusing, and you can feel like you're doomed no matter what you use. And for those patients, I would say, and what I use on my children is I use physical sunscreens, and I'm okay with it being nanotechnology. So the zinc and titanium.
Thank you, Dr. Lee. So I know we only have time for a few more questions. I want to assure everybody that the questions that were submitted in the chat box that we're not able to get to today, I'll work with Dr. Lee to get some answers out to everyone via email. Dr. Lee, I think we have time for one more question. Can you just share a little bit about what are the best topical treatments for non-scarring alopecia, and do hair transplants work for scarring alopecia?
These are great questions. So maybe I'll tackle the second question first. So hair transplants can work for scarring alopecia as long as the scarring alopecia is burnt out. If it's still active, you're at danger of losing those hair transplants. And so I'd work very closely with a experienced hair transplant surgeon for that. And then the first question again was, can you?
What are the best topical treatments for non-scarring alopecia?
I think it all depends on what the etiology or the reason for that non-scarring alopecia is. I tried to discuss briefly during the talk that non-scarring alopecias, they can come from a wide range of different etiologies, including the telogen effluvium if you're really sick. For that form, there really isn't a therapy that you just really need. Your body needs to recover from that shock or stress of being so sick. If it's a medication-induced non-scarring alopecia, you have to remove that medication. If it's alopecia areata, we want to do injections of steroids. Probably is one of the most commonly used therapies. If it's acute lupus, oftentimes we want to gain control of the lupus itself, and that would be an adequate therapy.
Thank you so much, Dr. Lee. This was extremely wonderful. We're getting a lot of comments from patients thanking you for being here.
It's my pleasure.
Presentation. So I will assure everybody that the questions that we're unable to get to, I'll work with Dr. Lee to get those answers to you. Again, thank you, Dr. Lee, for being here. I know you have many commitments tonight and appreciate your presence. So have a good evening, Dr. Lee. And I'd like to just, if everyone can stay for just another quick minute, I will be sure to share, we'll connect with Dr. Lee to see if he will make the slides available, as I'm hearing from many that they'd like to have the slides available, as well as some of those questions, answers to those questions. So just a friendly reminder to please spend a few minutes completing our evaluation that has been embedded into the chat box. Again, your feedback is so important. And you can also include any additional questions in the evaluation. So we please encourage you to complete that before you leave us today. I'd also just like to invite you to our upcoming programs. In honor of Lupus Awareness Month, we still have 2 more to go. On next Tuesday, May 17th, Dr. Ruth Fernandez-Ruiz is going to be joining us to talk about lupus and mental health. This program is actually going to be conducted in Spanish. Last but not least, on May 24th, we're partnering with the Lupus Foundation of America and the HSS Lupus and APS Center of Excellence for an interactive presentation titled Navigating Bias in the Healthcare Setting. So we hope all of you are able to join us. We thank you for being here tonight. Happy Lupus Awareness Month. And if you're interested in these upcoming programs, we please ask you to register. Those links have been added to the chat box. Again, thank you so much for being here. Have a wonderful evening and happy Lupus Awareness Month.